Thanks, Richard, and everyone. So I just joined King's a couple of months ago, and I was asked to talk about Japan, where I come from. But I'm wearing the hat at King's right now, so I'm the professor here to lead the Institute for Population Health. And I have started working with Richard, and I was asked by Richard, why don't you just present what I have done in Japan? But also, there are huge implications for here, and not just for King's, but also the UK, but also global. Because we are talking about the four tsunamis in health systems. I'm currently an advisor to WHO Director General Tedros, and in his inauguration speech, he mentioned about the four tsunamis, which are happening everywhere, not just in the UK, Japan, United States, or Europe, but in Sierra Leone, in Africa, and also particularly epicenter of this four tsunamis is always in Asia. So population aging is the top one, non-communicable diseases, chronic diseases, and of course exposure to health technologies, which of course boosts the cost. And obviously globalized influence, not just healthcare, but also movement of doctors, patients, many things. So four tsunamis happening everywhere. And Japan is obviously one of the most aging society in the world. The problem is not just aging, but also the population is shrinking over the past 10 years. So what to do? People coming to King's in 2011 when we had a big earthquake and nuclear disaster accident, I read a Lancet series of Japan. And Richard Hutton, who is the editor-in-chief of the Lancet, said Japan is a mirror for our future, saying Japanese health system is a kind of parameter, not only for Western health, but also globalized community. So that's why the government of Japan is stepping up its effort, not just to reform domestic health, but also Japan is very committed to global population health for the past decade. So when I did the Lancet series, we use the WHO framework for health system performance assessment. Because to understand health systems, we need to have a framework. Otherwise, it's very difficult to compare with countries. And when I joined WHO in 2000, we developed this kind of health system performance assessment. And it started from your left-hand side. There is a stewardship of the government, but also we focus on three inputs: money, resources, and service provision. On the right-hand side, we have three major goals, and the ultimate goal is obviously health improvement in terms of healthy life expectancy, but also we focused on fair financial contribution as well as responsiveness to people's non-medical expectation. We initially started from three goals: healthy life expectancy, fair financial contribution, and responsiveness to people's non-medical expectation. And we measured for, at that time, almost 190 countries. And most of them do not have any data set. We did a bunch of extrapolation, which evoked huge controversies at that time. But I think it's time to go back and do more health system performance assessment, because the health system challenges are changing for the past 2 decades. And we are shifting from healthy life expectancy more on effective coverage, which is the coverage of essential intervention to increase the quality of care for those who are in need on time. Because healthy life expectancy is not so sensitive to any changes to inputs. So, for example, a good example of effective coverage is vaccination. So we measure, for example, measles vaccination coverage, but we'd like to know, for example, antibody titer against measles rather than simple coverage. So we are shifting from crude coverage to effective coverage as a metrics for health system performance. And that's exactly what I'm advising Tedros to go for WHO to move ahead, not just a simplified health life expectancy, which is building upon a bunch of assumptions and also very insensitive to any change in input. And a good marker, for example, for the UK is effective coverage of antihypertensives. Because this is a study, it's really old, which I did for the Lancet, but this is a coverage of hypertension and also hypercholesterolemia. And the extent of the coverage, for example, if you on the left-hand side, the coverage, the left area is those who are undiagnosed. And blue one is good one, those are diagnosed, and treated, and controlled. That's exactly what we want. But surprisingly, in Japan, through the universal access and relatively low cost, we have a huge number of undiagnosed patients. It's surprising. I presented this to the Japan Medical Association. I was heavily criticized, but this is exactly the data we have from the National Examination Service. And this is not specific to Japan or the United States, everywhere. I'll show you the data in the UK, but the problem is not access to medicine. It is more on effective coverage. And also I moved ahead to do more on the national and subnational rhythm disease study. And also I think you gave you a similar study a couple of years ago in the Lancet. But we showed that stagnating healthy life expectancy, still Japan is the top in the world, but there is a stagnation and also widening gaps across the prefecture. Prefecture is a state. And there are some, hypotheses we can generate. Difference in prefecture will be due to difference in risk factor distribution or differences in input, like doctors, nurses, or money. Or given the same level of input, there should be some efficiency matter for activities. Or something outside social health sector, i.e. social determinants. So, for example, there was a lot of argument in the prefecture level. We need more doctors. We need more money. So on the left-hand side, there is a simple correlation between health outcome and the health expenditure by prefecture. There is no correlation. So we are now and also we looked at risk factor distribution by prefecture. There is some, power of statistical power to explain the differences across prefecture due to distribution risk factors, but not much. So we're now speculating it's more on health system performance or social determinants. Somebody mentioned 60% are due to social determinants. But social determinants is also very difficult to prove. If you say this is due to inequality, this is social deprivation. But if you talk about social deprivation, there are many things to think about. So we have to be very careful to frame this question and the way we analyze it. So that's what exactly we are trying to do here at the KIMS with Richard and others. And when I was in Japan, I was advisor to the health minister, and we developed vision for the next 2 decades, because ministry didn't have any vision for the future. And we published in 2016, which is called Healthcare 2035, is for Japan for the next 20 years vision. So we propose simplified 3 visions. One is value-based care, and second is social determinants, third is global health. And this is becoming a very, very important report for the Japanese government, and we are moving ahead with that direction. But surprisingly, next year, 2016, UK Academy of Medical Sciences published this report, improving the health of the public by 2040. And I got a copy. When I read it, I thought, oh, they just copy and pasted which we did. No, seriously. The point is, they did an independent committee, but the messages are very much consistent, surprisingly, because the UK report says there should be a public paradigm shift from public health, top-down, or traditional public health to health of the public, meaning we need to have health in every sector. And Japan is also proposing that health is not a matter of Ministry of Health. After my talk, that person from Ministry of Industry, we gave a talk of the Japanese government vision, because currently the Prime Minister, his office, cabinet office, is really dominated by the Ministry of Industry. So Ministry of Health doesn't have any power. So as Minister of Finance before, everything was determined by Ministry of Finance, but now industry and also data regulation and movement towards something new is the really core of the Japanese conspiracy. So that's why I was invited to join here. And before leaving Japan, I chaired the committee which is called Future Innovation Working Group, and organized by the Ministry of Health and Ministry of Economy. Usually they don't talk to each other because the Ministry of Health is a regulator and the Ministry of Economy is trying to regulate. But given this strong cabinet and also Prime Minister's vision to reform healthcare and social care, they work together. But the good thing about this is that the mission was to talk about the issues around 2040. So they thought they don't have to do anything right now. Or we can talk for 2040, we can dream in many things, and come up with very fancy idea, or we have a smart city, everybody has some sort of gizmo everywhere, everybody is monitored, and we receive any good intervention, personalized, optimized at the point of care. But the point here is, so we talked about moonshot, you might talk about this, and the government set aside a huge amount of money for this. But moonshot, yeah, I can come back to this. But we talked about a lot of things. The committee is very complicated, not that fancy as military is. It's very relevant, it is a manual process of how you think about the future. Lots of things. And with the community's social change, we need more mutual support, quality of life issues, change of the definition of health, not just well-being, but also beyond to some behavioral change, blah, blah, blah. So we end up, but surprisingly, we talked about moonshot. There are many issues about technology and industry and social change, but eventually we end up with two key messages. This is the usual diagram. We shifted from hierarchical unidirectional model to network-based and interconnected model, and expanding the stakeholder from just the usual public sector to private and civil society group, and new stakeholder will be playing a major role. But two messages is one is investing in, of course, R&D program, which you might talk about it, and also empowering individual and harnessing inclusiveness, mutual support, which will be the key. And on top of that, developing social ecosystem. The reason why we end up with this, and this is usual, but the importance of the social ecosystem change. Because when we talk about integration, value-based care, social determinants, don't we talk about that then for the past 2 decades? There's nothing new. Healthcare is very bad about changing themselves. So let me, here we talk about Japan is also collaborating with the United States to come up with a grand challenge fund, and also we have a bunch of money to invest in this area. But the problem is, when we talk about the moonshot, we need to think of backcasting. The important thing is not what we're dreaming for, it is about what we should do now. So that was the frame I did as a chair to the committee. So I don't believe in revolution, because revolution most of the time fails, but instead evolution is very important. We have a bunch of ideas, there are a bunch of activities, but we're not just looking at 20 years ahead of time, but we should seriously think about now. And so why we are here today, so again, what we should do now, but also what's special about health and life science. Of course, market failure, and there are a bunch of usual excuse justification. Why healthcare and life science so slow to change themselves? Because the issues have been already identified so many years. But why? Well, finally, it's important to share these ideas together. So it's a great opportunity to be here at King's, and we have a huge potential to do things together. And thanks very much.